How are you? Okay, good. Okay. So did you say they're working? Nathan? Nathan? Must not be me. Turned on. Well, I think it's just that he hadn't. I didn't even see him up there. We ready? Okay. Great. That's a high sign. Hello, everyone, and welcome again this afternoon. Thanks to everybody for coming. I want to take the opportunity to thank you all for your support of our clinic here, our educational experience out here. It makes a lot of difference. And, as you know, we're training young doctors during their residency, 3-year residency in internal medicine, to be ready to go into the community and be card-carrying internists. Some of them will go on to fellowships in specialties, in medicine subspecialties, and others will go into general internal medicine, which used to be being a PCP, right? Do you know that most going into general internal medicine now are being hospitalists? So they're indoor docs. They meet you at the door when you have to be admitted to the hospital. That's been quite a sea change in medicine and in America. In fact, you might find this interesting. I think it's still true. You can check me on this. I think the hospital medicine training, residency training specialty is the first medicine specialty to be created outside an academic medical center since something like 1960 or something. In other words, that's a specialty that got developed because community hospitals needed doctors well trained to take care of people in the hospital, and so a specialty got created, and it's turned out to be very popular in a lot of ways. And some experts write that it's probably saved primary care in this country, because primary care had been kind of declining in terms of numbers of new doctors going into primary care. Part of it was, I know I experienced this the first half or 2/3 of my career. It's trying to do both outpatient and inpatient. I remember those years I was doing that, and there was this constant notion in my mind, I could do either one of these jobs really well. It's trying to do both of them at the same time. It's hard. The days were invariably long, and even when you weren't on call, it was long. So anyway, so that's just putting it in context what we're doing, and so they're kind of at a critical time in their careers and their training, and again, the reason I'm thanking you for your contribution. It's no small thing. The fact that they get to work with individuals, with patients who appreciate what they're doing and are so gracious in saying so. So today, as you know, and as the sign reads, we're going to be talking about kidney disease. It occurs to me that kidney disease is one of those things that we all are comfortable with the word, with where it's located, that kind of thing, and we hear it talked about a lot. But it's kind of underappreciated how vital the kidneys are to the whole human physiology, the way our bodies work, and our metabolism, and how the body gets rid of things and processes things. And so testimony to that is what how bad things are when your kidneys completely quit functioning. And so they're going to enlighten us about this, give us the facts and the details about how that works and how it works when it's not working so well. So with that, I'll introduce these two. These are our two residents who've been on service this block. So they're here for a 4-week block. This is their last week, and typically this public presentation is on the last Wednesday of their rotation here. So who's going first? Dr. Labana. So Win Labana is a native Arkansan. Little Rock area? Central Arkansas. Little Rock? Little Rock, yes. And so grew up in Little Rock, went to UALR, and then to UAMS. And that should be an indication we've got him for life. But no, we're about to lose him. And we're about to lose him to New York. How about that? Upstate New York. Actually, what we helped him most on, I think, is we helped him discover that what he really wanted to do was not internal medicine, but psychiatry. And, you know, when someone tells you that, you say, if you're thinking about being a psychiatrist, that sounds like a calling. You know, we're not going to talk you out of that. Although we tried, to tell you the truth, we tried. He would, having gotten to know him, this is his second time out here, having gotten to know Win, I think he's going to be a great contribution to the medical profession, even as a shrink, especially as a shrink. So he tells me he's had a good experience out here. I think he's telling the truth. Yeah, listen, I didn't ask any other questions. Maybe it's because we didn't disclose that, and you know. What else can I say about him? But anyway, it's been a pleasure working with him, and just here in a couple of months, he'll be off to Albany and learning things non-Arkansan up there. So Dr. Hoos, our upperclassman, he's not from Arkansas. He's from small town Kansas, Parsons, Kansas. But what got him to Arkansas was Hendrix College. So he went to Hendrix, where he met his fiancée, Erica, who's also one of our residents. Y'all got a date? 24. Gosh, I thought you had to have a date. We've been talking engaged for quite a while. So they had a good experience at Hendrix. I guess a really good experience at Hendrix. You know, that's my alma mater. So we can dwell on that, and I'll brag on him for that. So okay, with that, we'll hand it over to Dr. Labana and tell us all about kidney disease.
Hello, I'm Dr. Labana. Just want to say thank you for allowing us to speak with you about chronic kidney disease. So the main function of our kidneys usually, just to dive right into it, is usually filter out toxins. There we go. Oh, sorry. Just a disclaimer before we start. This is a very broad and general overview. If you do have kidney disease, please follow the recommendations of your nephrologist and your PCP. They definitely know your health and your kidney disease better than we do, but just to provide a general overview here. So, like I said, the process or the function of the kidneys is usually to filter out toxins and preserve the functions that are important for fluid balance in our body. Usually that's the big things we look at. For a chronic kidney disease, is normally a decline in your function that normally lasts for 3 months. So there's a few different ways we look at kidney disease. If it's acute, it's usually between hours to days of kidney function kind of starting to decline. And we see symptoms of that usually pop up if it lasts for a little while. So subacute would be from a few days to 3 months. And then if someone has chronic kidney disease, it means their kidney function has declined for 3 months or longer. Some of these definitions we just want to point out because we'll mention these quite a few times. EGFR is the estimated glomerular filtration rate. That really tells us how well your kidneys are functioning, if they're filtering at the rate that a normal kidney should be filtering at, or if they're injured, or if they're declining in function. This rate will typically tend to trend down. Creatinine is a waste product that the kidneys usually are able to filter out. However, with creatinine, if it starts to get elevated, we start to worry about something else going on. We also tend to look at the urine since the kidneys do tend to filter out fluids and make urine. Some components of the urine are very important for us to evaluate how the kidney's doing. One of those things is albumin, which is a protein in the liver that kind of helps keep the blood fluid normal as it is. And then lastly, you might see ESRD, which means end-stage renal disease. This is typically patients with kidney disease who have gotten to a point where they're needing dialysis for treatment. So usually when you go to your doctor, they'll do screenings for things like colorectal cancer or breast cancer, just things we do by colonoscopy, stuff like that. Our guidelines don't usually want us to screen for kidney disease, and most of the time the decline in function is found incidentally. However, there are a few different ways we can screen for it if we do believe that there is something going on. One of those things, like I talked about, is the urine protein level. An increase in the urine protein is an early indicator of something happening with the function of the kidneys. For example, one of the most common reasons people have kidney disease is because they have diabetes and hypertension that may be uncontrolled, or even sometimes it is controlled and it just progresses that way to a point where patients go into kidney failure. So with patients like these, especially diabetics, we see an elevation in protein in their urine pretty early on, and that gives us an idea that we should be monitoring them over time to make sure we're doing everything we can to kind of prevent the kidneys from getting worse. The other thing is the serum creatinine level. This is usually the first sign of kidney function impairment. With the general number that we look at being under 1 for creatinine, if the number starts to rise, we think that patient has a kidney injury. For acute kidney injury, like I talked about, when someone has like an injury that's in the short term, we'll see the creatinine increase by 0.3 from their baseline. So the normal is under 1, but we do look at baseline because it can vary between people. Usually in chronic kidney patients, what happens is they'll have this like change in their baseline in creatinine, and for some patients they may be around 1, but we often see patients have a baseline closer to like 2, 3, 4, and this helps us kind of gauge how their kidneys are doing because their baseline is going to change to a higher creatinine level. So if they have a change of like 0.03, we know that they have a new kidney injury on top of their chronic kidney disease. To diagnose it, there are a few markers we look at, like we talked about the GFR, which is the glomerular filtration rate. If we see this kind of decrease and stay low at a certain point for 3 months, we kind of have an idea we're dealing with a kidney disease. And at that point, we want to take some more actions and evaluate if this really is kidney disease or if this is something that we can fix in the acute phase to kind of help the kidneys. And it usually varies by patient. For patients who are, for example, young and very big bodybuilders, if they have a high creatinine diet, high protein diet, then we'll use something called a creatine clearance GFR. This is a specific GFR we use in those cases just to kind of gauge if the kidney function is in fact due to just the kidney function declining or if there's something else we can fix. After that, if we don't use that, there's another way we use, which is a random urine protein. Like I talked about, if their protein's elevated, we would do this test randomly if someone comes in. So it's just a one bullet point usually that'll kind of tell us that we need to be concerned about something. And then if we are concerned, we'll do something called a 24-hour urine collection, and we'll look at the protein in that. The average person filters out less than 150 milligrams of protein a day. So if this rises in the 24-hour collection, if it's higher than it should be, that's another indicator for us. Another thing we do is we can also break down the total amount and see if the filtration rate per hour in those 24 hours is something we need to be concerned about. We don't always do kidney biopsies to determine etiology. Oftentimes we can do it through labs. Um, so, for example, if someone has microscopic hematuria, which means if they have microscopic blood in their urine, um, we'll start worrying about a specific etiology, normally stemming from like the anatomical basis of the kidney, like glomerular disease, or if they have something called sterile pyuria, which is pus and white blood cells that's in the urine, but there's no source for them to be there, like bacteria. Then we'll think maybe about something else going on, and like if they have sterile pyuria and eosinophilia, which is a type of blood cell, we may think there's something like autoimmune happening, or if they have like a hypersensitive reaction. So those are the kind of methods we usually use to determine the etiology. However, those don't always work out. Like I said, sometimes it can be a structural anatomical problem, and taking a biopsy of the kidney in those times can be very beneficial for us to like identify why someone might be having a decline in their kidney function. So, like I said, oftentimes patients don't present with kidney injury or kidney disease. It's normally found incidentally. If someone goes in, we'll do some blood work, see the creatinine kind of elevated or GFR kind of low, or we might do like a urinalysis, which is checking their urine, and we might see some protein or creatine in that, and we kind of start to realize there's something going on with the kidneys. So usually the symptoms aren't always present. But some of the symptoms that are common are like lower extremity edema or edema in other places, or hypertension that's worse than what someone might usually have. If depending on the severity of the disease, some of these other symptoms might come up like weakness, fatigue, anorexia, vomiting, pruritus, which is itchiness, and that usually happens when someone's kidney isn't able to filter out things like urea or uric acid. The elevation in that typically causes things like itching. And in patients with very severe kidney disease, if the urea is very uncontrolled, they might have things like encephalopathy or seizures. The interesting one here is uremic frost. It doesn't usually happen very often anymore, just because we have really good treatment modalities now, and because we have things like dialysis, we can usually prevent things like uremic frost, which is crystallization of urea on the skin, and it looks like white flakes usually. So it's not something we see commonly anymore, but it is something we keep an eye out for in case we see something weird. So we have to break down the kidney disease in stages, because depending on how someone has progressed in their disease, the treatment modalities and their outcome overall based on that are dependent on where their kidney function is. So there are a couple of ways we kind of break down the stages. One of the ways is by looking at the glomerular filtration. This is the method of kind of looking at that. And the other way is looking at albumin filtration by the kidneys. So here we break it down into actually 6 stages, although it says 5. You'll see that 3 is broken down into 2 stages. So at stage 1, the GFR will normally be above 90, which is actually normal. At stage 2, we start to see a little bit more of a decline in the function, and the stage with the GFR will be between 60 and 89. Stage 3, again, is split into 2 stages, 3A and 3B, because here we start to see a varying in outcomes and treatments for patients. 3A is from 40 to 59 for the GFR, and 3B is from 30 to 44. And then we have 2 more stages after that, with normally patients in stage 5 being identified as end-stage renal disease. So these are the patients who will be good candidates for dialysis. I want to turn this over to Dr. Hughes to go over the remaining of this PowerPoint.
Hello, everyone. So this is the way that most doctors that you talk to are trained to think about kidney disease. For the longest time, this glomerular filtration rate, this GFR, was really the kind of key laboratory value that most doctors look at to evaluate kidney function. Here in the past decade or so, just because it takes so long for research to get from research laboratories out into publication and then out into the communities where doctors who see patients every day, use that information. It's taken quite a long time for this kind of picture to start becoming more mainstream, but it is kind of the gold standard on how we evaluate kidneys now. Along the left side of the screen there, you'll notice the G1, 2, 3A, 3B, 4, and 5. Those are the same categories that you see here. What we've got across the top is a new understanding that the amount of protein that we spill into our urine affects the severity of the kidney disease. It's something that we didn't used to think about very much, but it's starting to become more mainstream now. The colors of the squares, so I should back up. This graphic was taken from a talk by the Kidney Disease Improving Global Outcomes Committee. It's a committee of top nephrologists who get together and think about new guidelines and new ways that we can help patients with chronic kidney disease survive longer and with fewer symptoms. So I wasn't able to find the talk that this graphic came from, just the graphic from the PowerPoint they published afterwards. They say that the color of the squares relates to prognosis, but they didn't tell me in regards to what. The major takeaway from this slide should be that the closer to the top left corner with the highest GFR and the lowest amount of protein in the urine, those patients have better outcomes. The more protein that you have in your urine, the worse that chronic kidney disease is. And so we're starting to look at protein in the urine as a better way to evaluate kidney disease. And then it's important to think about the causes of chronic kidney disease. Why does this happen? You'll see the largest chunk, that 42% red at the bottom of the circle graph, the pie graph, is type 2 diabetes. That is by and away the greatest cause, the most numerous cause of people to develop chronic kidney disease. Not too far behind it there, the orange slice at 28% is high blood pressure. This is one of the reasons why we harp at you when your blood pressure gets high. We're really focused on trying to get that blood pressure under control so that the pressure of your blood moving into your kidneys doesn't cause long-term damage. Even if you don't have symptoms from the high blood pressure, that chronic pressure over time, over decades and decades, ends up hurting the kidneys. The remaining segment of the circle graph there is kind of split up into a whole bunch of kind of odds and ends groupings. We don't think about them all the time. Most of the time, as you can see there, it's the type 2 diabetes and the hypertension that cause the kidney disease. But if someone comes in and has kidney disease and that doesn't seem to explain it, we'll start looking at some of those other causes. And so this is a really good segue into hypertension. It varies from person to person based on what other factors may be present in your health, but for most people, the blood pressure goal is around 130/80. As we get older, we know that the blood vessels get more stiff, and as a result, the blood pressure goes up. And so it wouldn't surprise me if many of you had blood pressure slightly higher than this, getting up into that top number being in the 140s or 150s. If it gets too much above that, we should do something to try to bring it down. But the people who are able to keep their blood pressure around here seem to do better. The problem with getting to this target sometimes is that in order to keep your blood pressure around 130/80, sometimes that means the medicines we use drop your blood pressure lower than that. And having too low blood pressure can cause a whole host of other problems. So we may settle on something just a little higher than that. Below there, the bullet points are some medications that we may use to treat hypertension. We found through decades and decades of research that lisinopril and other drugs that end in PRIL, along with losartan and other drugs that end in that sartan suffix, help protect the kidneys from, even if you have type 2 diabetes, taking one of these medicines can help delay the progression of chronic kidney disease. There are some papers that have started to come out here that hydrochlorothiazide, or HCTZ, is a medicine that can actually, in some studies, it's been found to progress kidney disease faster than normal. Other papers have found that it plays no role, so that's still kind of an open question. And then furosemide, or Lasix is the trade name of that one. That's a water pill, and it may help your kidneys balance the salt and water appropriately when they're starting to lose that function. So like Dr. Lubana mentioned at the top of his segment of the speech, we primarily think of the kidneys as being a filter that helps make urine and eliminate waste products through that. But the kidney has tons and tons of other functions that we don't always think of. It's arguably the most complicated organ in the body. just because of the amount of functions that it performs and how complicated of an organ it is. You can think about, the size of your kidneys. In the back, they're probably 3 or 4 inches tall on, one on each side, obviously. A dialysis machine, you may have seen, they're about as tall as I am, in a, probably 2-foot square box, about as tall as I am. It can do about 30% of what your kidneys can do. So they're small, they're tiny, but they're really, really powerful, and they do a lot of cool things for us. As you develop chronic kidney disease, one of the things that may be affected is disorders with bones and your minerals. So the kidneys are responsible for converting vitamin D from its inactive form to its active form. And as chronic kidney disease progresses, that function is one of the ones that's also affected. And so vitamin D helps us balance calcium levels in our body. And if we don't have the vitamin D to help bring calcium from what we eat into our bodies, then the body will try to get that calcium from our bones, which is really unfortunate. That weakens those bones and can cause people to have fractures, hip fractures, arm fractures. And so just another good reason to try and keep on top of the chronic kidney disease, to keep those bones as strong as long as we can. Anemia is another problem that happens as chronic kidney disease progresses. There's a chemical called erythropoietin, we call it EPO for short because that's way too many syllables, that is responsible for signaling to the body to make more red blood cells. That's a function that's mediated by the kidneys. And so as chronic kidney disease progresses, the kidney loses its ability to produce that EPO, and the body stops making red blood cells, which can lead to anemia. That can cause people to feel tired, cold, sluggish, kind of cause the color to drain from our faces and bodies. We look really pale, kind of causes people to look sickly. And so this picture was a lot more clear on my smaller screen than it was on the projector here. Along the left-hand side is the stage 1, 2, 3, 4, and 5 that we talked about with the glomerular filtration rate earlier. And the graph here is talking about the percentage of people that develop anemia with each stage of chronic kidney disease. So there at the very top, in stage 1, less than 1% of people have anemia. But by the time you get down to, even at stage 3, that would be both at stage 3A and 3B, 6 to 8% of the people in stage 3 have anemia. But that makes a huge jump as we drop down to stage 4 and stage 5. With stage 4, they're having 50 to 60% of people in stage 4 kidney disease having anemia, and 85 to 100%, virtually everyone with end-stage renal disease developing anemia. And then I wanted to end the talk here by talking about dialysis. This is something that many people have heard of. Many people may know someone who is on dialysis, but may not necessarily have a really clear picture of what dialysis is. So there are 2 forms of dialysis. Hemodialysis is the one that most of us are familiar with if we've thought of dialysis in the past. Peritoneal dialysis is a second option that works well for many people. Hemodialysis is probably the easiest to understand, so we'll start there. There's a couple of ways to do it. The best way to do it is to have a surgeon go into the arm and form a connection between a vein and an artery, and that allows them to put the needles in there so that the hemodialysis machine can act as your kidney. So you've got one needle that goes in that draws blood out, runs it through the dialysis machine, and then a second needle that puts all that blood back. And so the dialysis machine itself kind of does the job of the kidney. It's got a big filter in it. It filters out all the waste products. We give back some fluid and try to do the job of the kidney outside the body. It doesn't help the kidney. It doesn't do anything to cure the kidney. It just does the job of the kidney outside the body. For many people, hemodialysis is something that's done 3 days a week. Some people do Monday, Wednesday, Friday. Some people do Tuesday, Thursday, Saturday. And it's generally about 4 hours at a time. So people will bring a book or their laptop or tablet. Some people lay there and take a nap. But it is a scheduled appointment that you would have at a dialysis center. The other way that we can do dialysis is peritoneal dialysis, and it can be done a couple of different ways as well. But basically, peritoneal dialysis takes advantage of the fact that really all that you need to clean the blood is access to a whole bunch of blood vessels. So the kidneys have a lot of blood vessels in them. That helps them clean the blood effectively. Your abdominal wall has a bunch of blood vessels in it as well, and so we can take advantage of that with peritoneal dialysis. What happens is there at the very top, you see the dialysate solution, the blue bag of fluid up there. We pump that bag of fluid into the belly and let it sit there for a while and let all the waste products filter out of the blood vessels into in the abdominal wall into that fluid, and then remove that fluid as urine. Some people need to do this several times a day, but it is something that's done outpatient, so you don't have to go to a dialysis facility for peritoneal dialysis. That's something you can do at home. Some people are able to get away with just hooking up their peritoneal dialysis at night. So they go about their day as normal, and then whenever they get ready to go to bed, they set up all the tubing and all the fluid and let it run overnight, empty it in the morning, and then they're ready to go back about their day the very next day. And that's something that would be done nightly. So. I know that was pretty quick. I really wanted to give just a surface level overview of kind of all things chronic kidney disease, and then I know you all have a bunch of questions, so I wanted you guys to kind of lead the discussion afterwards. I saw you first. Yes. So the question was, can people survive if they have just one good kidney? If you have a tumor or a cancer, let's say, on one side, can you survive with just one kidney? Yes, many people do. In fact, there's been a big push here recently for people to become organ donors. You can register online, and if you were ever a match for someone, they would go in and actually take one of your kidneys for donation, and you would live just fine with the other kidney. We have to be a little more cautious with what medications we give to those people, just because they've only got one good working kidney at that point. But many states are starting to put in programs where if you have donated a kidney, you get moved to the top of the list for a kidney transplant if you ever need one in the future, to try to encourage people to donate more. Good question.
And at what point on your 5 or 6 levels would someone be a candidate for a kidney transplant? You don't wait till the stage 5, 6.
Correct, you don't. That's a really good question. I think by the time we start getting into the end stage of 3B or the very beginning of stage 4, it's worth having a conversation about whether you're a transplant candidate, just because it can take so long for a transplant to become available. But that would be a conversation that you would have with a nephrologist. Certainly at that point, they would go through all your risk factors and decide on when the appropriate time to place you on the transplant list was.
I think I'm right. They would never take a donation and plan it before stage 5, but they'd be ready before stage 5 to do it. Fair to say. So if you get to stage 4, and especially for young people, you get to stage 4, you're pretty sure they're going to wind up at stage 5 sometime. You're talking at that stage about anybody in your family that might be a candidate, and so that there won't be too much lag time.
Did I see a question over here somewhere? No.
Yes, sir.
You mentioned creatinine as a marker for kidney function. What is the physiological effect of creatinine if it does increase to high levels?
Creatinine itself doesn't seem to do a whole lot to the body. It's a breakdown product of muscles that the kidneys, for the most part, get rid of. There are some other chemicals in the body that we can use to, really more accurately measure kidney function, but they're not as common tests. Creatinine is a pretty good ballpark. as I said, it itself doesn't seem to do much to the body as it builds up. The bigger problem is the BUN, or blood urea nitrogen. That's a waste product from protein breakdown in the body, and it's responsible for many of the symptoms that were up on that slide earlier. The confusion, the itchiness, this uremic froth. It literally looks like someone is it's the worst dandruff you've ever seen. I should have put a picture in here. It looks terrible. The BUN would be the more concerning number. Creatinine's just a really good marker for how the kidneys are doing, how they're filtering.
It just tracks so well with in parallel with what the kidney function is doing. And when you find it elevated, it's about the only thing that'll elevate it like that.
One of our tests is a basic metabolic panel. It's got a handful of electrolytes and then the creatinine. And so it's one of the most routine blood work that we order, and it's really nice that it's included there. Makes it cheap and easy to get. Yes.
We're getting into the summertime. Are there any drinks that we should stay away from because of kidney disease?
I should always counsel you to avoid alcohol, and then caffeine has a kind of water pill-like effect to it. Water is going to be the absolute best thing to drink. If you don't like the taste of water or are looking for something a little more flavorful, sugar-free sports drinks have some electrolytes that can also help out with the kidneys. But in general, just staying hydrated and keeping those kidneys hydrated would be the most important thing.
I've got a friend right now who's a good deal younger than me that I just friend through church, who's waiting for a kidney transplant. And she early on thought, my sister's a natural one and she's willing and she's, but they wanted them to submit a list of other people. Turns out there was positive protein in her urine. And so that's off. She may have latent kidney disease. We can't take her kidney. Her husband, who's a science teacher in high school, noted the next 8 people all had protein in the urine. And he says, how often does that happen? And he questioned this. They ran all of them again, and none of them had protein. So it turns out her sister is a candidate, but I thought, wow. If you'd asked me, does that happen, I'd say never. We're too sophisticated for that, but some simple little thing like that. Are there other questions? Yes.
One of the things that is so discouraging about kidney disease, there's no medication for it, really. And the only thing you can do is either wait until you have to have dialysis or a transplant. Isn't that true?
Well, that's why I was saying that we try to, when we start seeing indicators that someone's kidney function is starting to decline, we become more careful about medications. We keep a closer eye on their kidneys too, because we can't necessarily fix your kidneys unless we put you on a transplant list and you get a new kidney. So dialysis is the only way your body can really get the function of a kidney outside the body. So we have to prevent your kidney from really getting to that point, and that's what we try to do.
Yeah. That leads to the next part of my question, and that is that I understand I do have stage 3 kidney disease, and I have been cautioned to be careful with my diet, particularly when it comes to protein. You didn't mention the possible influence of diet in your lectures. I wonder if there's anything important about that.
I'm sure there is. That's why I mentioned it'd be best to speak with your nephrologist and your PCP. They know your health best. Kidney is one of the organs in the body. There's a lot more, so we have to keep a balance throughout them all, and diet is one of the better ways of kind of keeping a good balance.
And if I may go on, what does the antidiuretic hormone do in the case of kidney failure?
All right. So antidiuretic hormone is a hormone that the body uses to hang on to fluid as much as it can. It's a hormone that gets released whenever the body senses it's dehydrated. And so depending on the stage of the kidney disease, the kidney will probably feel like it's not getting enough blood flow as the function worsens. It may notice that it's not doing a good job, and so it may signal that the body is dehydrated and send more ADH, even if it's not dehydrated. That can lead to some of the volume overload that we may need to use the diuretics to try to overwhelm that ADH.
And I wondered, are we not supposed to eat very much protein? Because you're usually told to eat protein. And is coffee bad?
One of the things we're told in medical school is, the dose makes the poison. If you're going to wake up and have, 1 cup of coffee in the morning, I'm not going to fault anyone for that. If you drink 2 gallons of coffee a day, I might tell you that there's an issue with that. Protein, generally, kind of the higher protein you can tolerate, the better. Like we were talking about, as kidney disease worsens, there's the possibility that you may be spilling more protein into the urine. And so trying to eat protein to replace that can be really helpful. Unless you have directions from your doctor telling you not to, yes, it's a good idea.
Yeah, if you had kidney disease, there'd be more of a limit on protein. Yeah, people who don't have kidney disease, generally protein, more often than not, it's a good thing to push. Right. Yes.
I would like to drill down just a little bit on this problem with high blood pressure. It's one of the major causes of kidney failure. And the literature I have read says that it can start harming the kidney at a range of about 130/70. And yet in our age group, most of us have higher blood pressure than that and supported by the doctor's advice. I don't know what to make of that.
Yeah, I was trying to allude to that a little earlier. The goal there was, 130/70, 130/80. That's the target for most people. The problem is as we get older, those blood vessels stiffen, and so naturally that blood pressure is going to go up. The problem with trying to get real aggressive and really bring it under that 130/70 is that sometimes we're too good at that. We start dropping your blood pressure down to 90/60, you're going to feel really lightheaded, dizzy, you may pass out, may fall down. We can cause all sorts of problems that are worse than having a blood pressure be just a little bit above goal. That's one of the reasons on that slide that I had about anemia. We talked about how at stage 3, 6 to 8% of people are going to have anemia, but there's that big jump between 3 and 4. I think that trend is pretty true of the other functions that the kidney has as well, is that everything's pretty well moderated if you get to stage 3 and stop. If we can stop you from progressing into stage 4 and stage 5, that's the ultimate goal. I think as we age and our blood pressure goes up, most people get to stage 3, and most people stop at stage 3. So if that's kind of the sweet spot where you're not going to have a ton of problems with the kidney, and we can try to avoid some of the problems of over-treating, that's kind of the happy middle ground. Yes?
I would wish you had a picture of exactly where the kidneys are in the body. And also, well, I would like to see it on behind what and in front of what, in the middle of what. And how would you feel physically if you thought you had a kidney infection or disease? Would something hurt?
Kidney infection is going to hurt for sure. most people will have what we call flank pain. It'll be underneath the rib cage, above the top of that pelvis, and on the side, whichever side the infection is in. Infection is usually just on one side. And so you'd notice some pain. It would probably hurt whenever you went to go to the bathroom to urinate. And if anyone were to tap on your back like this, it would just about send you out of your chair. It can be incredibly painful. As far as kidney disease, just the chronic progression or even acute injury, most people don't have any specific symptom. I don't know that anyone's ever come to the doctor and said, "Hey, doc, my kidneys hurt," or I'm having kidney problems, unless they've talked with a nephrologist and are kind of aware of the symptoms. The symptoms that are there are pretty non-specific. A whole bunch of things could present with any one of those symptoms, and fortunately, the kidney function numbers are on one of the most common tests that we order. I did not put a slide with the anatomy. That would have been a really good thing to do. That was a good point.
So the kidneys on each side are positioned behind the bowels. Okay, they're right next to the aorta and the large vein, the vena cava, in the back of the abdomen. So they're situated in the back, and if you had pain from a kidney, say a kidney stone, it would often be in the flank right there on both sides.
What would you tell us in regard to observing the urine after you urinate that might be something that you would go to the doctor for, the color of the urine or the volume of the urine? What does that have to do with the kidney function?
Certainly, if you notice blood in your urine, that's something to at least call a doctor about. That blood can be just as red as you think of with blood. If you've got just a little bit of blood, they say it can be kind of tea-colored urine, would be something to keep an eye out. If it's really, really dark yellow, most of the time, that may be a sign that you're dehydrated. We'd recommend that you drink some more fluid and see if that lightens the color. In general, urine should be straw-colored. And then if your urine ever looked cloudy, that is, you couldn't see through it. It can still be yellow, but you should be able to see through it. It should be transparent. If it were ever cloudy, that may be a sign of an infection. But you should be feeling bad before you notice that.
When something goes wrong at dialysis and you miss that dialysis treatment, what's going to happen to your kidneys?
So, like I said earlier, dialysis doesn't do anything to treat the kidneys or make the kidneys better. Once the kidneys get to that point, they're not going to recover. Most dialysis schedules are Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. So kind of built into that schedule, there's a 3-day block where people don't get dialysis. Most people handle that just fine. By the time you start getting to 4 days without dialysis, if you had a Monday, Wednesday, Friday, and you missed your Wednesday session, by the time Friday rolled around, most people are feeling pretty bad. They're feeling really sluggish, really tired. They may not be thinking clearly. Their blood pressure may be really high because they've got all this extra fluid buildup and waste buildup that they haven't been able to get rid of. So their blood pressure may be high, and they may have all the symptoms that go along with that. Maybe some headache, maybe some chest pain.
Yeah, I agree with what he said. And for most people who may be pretty healthy except for their kidney disease, they wouldn't feel great by the 3rd or 4th day, but it wouldn't be particularly harmful either. They'd get him back on dialysis, everything's fine. But there's some people dependent on their dialysis because they also have heart problems and are prone to heart failure if their fluid builds up too much. So they get away from dialysis even 1 or 2 extra days, and they're starting to build up fluid. And so it varies kind of from person to person and case to case how long you could go without it.
Yeah, it exists on a spectrum for sure. There are lots of people who need dialysis but don't have health insurance, as you might imagine. And so hospitals, most hospitals have programs for people without health insurance to receive dialysis. But due to the volume, due to the number of people that are in that position, they're only able to offer that twice a week. And so it's not uncommon for people to have, you know, a 3 or a 4 day break between dialysis, but you get much beyond that and people don't feel real good.
Good questions. Okay.
I'd like to know more about what causes kidney stones.
There's a bunch of causes of kidney stones. There's 3 or 4 different chemicals that can actually compose the crystals that make the stones. They all have their own causes and their own treatments. And so when someone develops kidney stones, one of the things we try to do is try to capture those stones so we can look at them under a microscope and see what kind of stones they are. Many times people are able to modify their diet, and that can help relieve kidney stones. Most people just need to drink more water and really help flush those kidneys. Some people need some medications to help prevent them from developing kidney stones in the future.
Yeah, I'm a little confused about kidney disease. You talk about disease, and I think of infection, and you say you can't. There isn't any medication that helps kidney disease, but if it's an infection, can't antibiotics or any other things have some influence on the case?
Sure. So if you have a kidney infection, obviously antibiotics would be one of the things that we would give, and that would help treat that infection. Kind of medically, we use the word disease to describe anything that's not normal. And so certainly infection is one kind of cause of kidney disease, but there's this kind of gradual deterioration of kidney function that happens mostly with type 2 diabetes and hypertension. And we can use some medications like lisinopril or losartan to kind of help slow that down. But the disease doesn't have to be something like an infection. It can be kind of a chronic deterioration that happens as we get older, as we live life.
Yeah, sometimes in medicine, like other areas of life, the terminology just falls into a certain way of referring to it. And here, when we're talking about chronic kidney disease, it's not really talking about some particular disease that attacks the kidney. We're just talking about when the kidney function declines to a point that it's called CKD from the earliest that it's detectable that way. But I can see how it's confusing for sure.
We don't use the terminology so much anymore, but we used to call these acute renal failure and chronic renal failure. I don't like the terminology of failure because I think it sounds a lot scarier than it actually is. You may be familiar with that from the terminology of heart failure, where the heart is failing, but it has not failed yet. And a number of years ago, we kind of switched our terminology from chronic renal failure to chronic kidney disease.
Last questions? Great questions, as always. Very intelligent crowd here.
Yes, absolutely.
Thanks so much. I appreciate your support and being here, and good presentation, guys.